Good afternoon, everybody. This is Samantha with ACRC Surrogacy. I am here today with the wonderful Dr. Mayor Olcha. He is one of a renowned oh my gosh, sorry, I'm like
Endocrinologist.
yes, endocrinologist, reproductive endocrinologist in the field. And he has agreed to meet with me today to kind of go over some of the frequently asked questions that we see in the industry. So we can move on and I'll give a brief introduction. Oh, before I do that, if you guys are interested in having a free consultation done by one of our intake managers on the IP side, you can go ahead and scan that QR code now, and we will have you set up a free consultation to get some more information on how you can start your journey now. Okay, so like I said, we have Dr. Mayor Olcha here. He has his own practice out of New Jersey, and it's absolutely beautiful. Your practice is phenomenal. When I walked
Thank
in
you.
there, it was just so bright and airy and lovely. So I'll let you kind of introduce yourself. Tell us a little bit about what made you decide to go into this and, some of your accomplishments.
Sure, yeah. So I am a reproductive endocrinologist. I do some embryology work, so there's some embryology involved, but I wouldn't call myself an embryologist necessarily. But thank you. I basically did medical school training, and then after that, I did a residency in general OBGYN and then a subspecialty in reproductive endocrinology and infertility. And sort of that whole path allows us to be experts really in the field of infertility, particularly as it pertains to things like in vitro fertilization and some of the deeper understandings of the biology of embryos. And so that's, I would say, is my primary expertise. I did most of my training on the East Coast, and I ended up doing my fellowship in New York. I worked in New York City and Manhattan for quite a bit, almost 10 years, and then eventually branched out and built Perch Fertility, which is a very special place for me. It's I think a little bit unique in that it's certainly not a factory style clinic. It's much more of a boutique personalized care. We definitely limit the number of patients that come through the door because we want to make sure that everyone gets 110% focus. I think the other difference there is that patients are not getting five different doctors and seven different nurses and four different techs, right? They sort of have this consistent team of people, and we know everyone by their first name. We know the story really well, and I think it's really pertinent particularly when you're doing things like surrogacy, which are more complicated, right? To be able
Yeah.
to have that personalized connection and not treat people like a number. And so I think that's why I built Perch. That's why I think it's really special. And I'm glad that you thought that your visit there was good. It is certainly designed to be bright and calming, and it's not meant to be a stressful environment. It's really meant to be an environment where people can kind of feel free, and they can take a deep breath, and they know that they're going to get really well taken care of.
Yeah, I mean, I actually didn't even plan on wearing the colors that your office is.
That's
That's
right.
weird. But yeah, I can absolutely say when I went in, I was the only person in the waiting room and I was treated so lovely, and it was just an amazing experience for my surrogacy journey. So you have done a fantastic job with that for sure. All right, so I think the next thing is just going to be asking some of our frequently asked questions that we see across the board from a lot of our intended parents. So I'll read them off to you just because we do have some people that may not be seeing the screen eventually. And then I'll just let you go ahead and answer those. Okay.
Sure.
All right. So first question we have is, can you explain the basic IVF process and how eggs and sperm are combined to create embryos?
Okay. This is only going to take me about 7 years to explain. So everyone
All right.
get ready.
Yep.
Let's try to kind of just simplify it and kind of give a maybe more of like a broad overview here.
Wonderful.
So IVF is essentially the process of making embryos, but it's done in a laboratory for the most part, as opposed to inside someone's body. And that's why it's called in vitro. In vitro basically means out of the body versus in vivo, which is the Latin word for inside the body. The process is essentially the same. It's just replicated in a laboratory so that we can control a lot of the different variables and make sure that we have really good outcomes at the end and make it an efficient process. The way I would explain it is essentially we are going to be retrieving eggs. So we're usually getting those from a patient or from an egg donor. We, of course, need the male genetics, so we'll retrieve sperm. Same thing could come from a partner, could come from a sperm donor or a sperm bank. And then together, those are combined in a laboratory under a microscope. Generally, the sperm are hand selected and hand picked, and then they are introduced into the egg microscopically. That egg, now that is combined with a sperm, we call that an embryo or a zygote. And so from that point on, once we've introduced the egg and the sperm, they can never be separated, right? They're essentially become one. And then we grow them very carefully in a laboratory in incubators, kind of like the incubators you would expect to see at a hospital for a baby, except at a much smaller scale. And so we are controlling things like the temperature, the humidity levels, the concentration of all the different gases in the air, like oxygen and nitrogen. We're controlling the pH, which is the acidity. We're controlling the media. And so we can tweak all these little variables to try and mimic the human body as best as we can. Um, we allow those embryos to grow typically for 5 to 7 days until we've uh, established that we have a very nice looking, what we call blastocyst, but it's essentially just a stage of development of an embryo that at that point we can transfer, or freeze, or test. And so that whole process from obtaining the eggs, obtaining the sperm, putting them together, growing them to create an embryo, that entire process we call IVF or in vitro fertilization.
Wonderful. Okay, that was definitely not 7 years. That was a lot better than the condensed
Yeah.
version. So thank you for that one.
Trying to simplify it, but I think, yeah,
Yeah,
that's
that
good.
makes sense. Okay, so question number 2. How do fertility specialists select the best embryo or embryos for transfer, and what factors influence that decision?
Sure. So this is something that has changed maybe in the last, I would say, 20 years. Um, IVF has been around for even more than that, right? More than 40 years now. So actually, this is constantly changing, and probably will change in the future. But currently today, I think most fertility specialists basically look at two separate metrics. So we are looking first at what we call the morphology of the embryo. And that is sort of a fancy way of saying, how does the embryo look to the embryologist's eye? When they look at it under the microscope and we're looking at the cellular structure that makes up this embryo, we can give that a grade. We can look at all the different cells, the different cell types, and we can say, is this a very good embryo, meaning physically, does it look really good under the microscope? Is it an okay embryo or is it a poor embryo? And we are looking at the way the cells are coalesced together. We're looking at the shape of the cells. We're looking at how large or expanded the embryo is, right? So we're looking at a number of different things. And there is a standardized system essentially for grading embryos, and it kind of comes down to a grade A, B, or C. And A would be the highest graded, B would be the most common grade, and then C would be the worst quality grade that we would allow to be transferred. So that's morphology kind of on one hand. And then the other element is the genetics of the embryo itself. And that is not something that is required. So we don't always have the genetics of an embryo, but more often than not nowadays we do. And so what we're able to do is take a little bit of DNA from that embryo, sequence the DNA in a separate laboratory, and then get back the DNA sequence which will tell us if that embryo has all of its DNA or is it missing some information or does it have duplications or extra copies. Both situations, missing or extra, are not compatible typically with life and have a very high miscarriage risk. So we look at both of those factors. What we're ideally trying to find is the best looking embryo morphologically with a normal genetics pattern. And then that's how we start prioritizing which embryos we think we're going to transfer first, second, third, fourth.
Okay, wonderful. Is that what they call PGT testing? Is that what you were talking about at the end part of that?
That's right. Yeah. So
Okay.
that genetics part is called
Yeah,
pre-implantation genetic testing,
got it. Okay.
specifically for aneuploidy or PGTA.
Okay, got it. Okay, so how does working with an experienced agency or fertility clinic enhance the IVF experience for intended parents?
I will tell you that our own internal policy is that when we work with surrogates, and I've worked with many, many surrogates, I've had a lot of success. We typically only work with surrogates through agencies. We do not work with an intended parent that just brings a private surrogate,
Okay,
like their neighbor or their friend.
right.
And there's a ton of reasons for this. First of all, the agency to me, as the clinic, is really crucial because it's the sort of middle person that's going to help communicate with the surrogate, communicate with the intended parent, make sure that all of the regulatory things are done properly, make sure that the legal elements are done properly, and sort of gives the intended parent and the surrogate an advocate for them. And to me, it kind of speeds up the process and allows everyone else to focus on what's really important, right? For us, we want to focus on making sure that we give the best medical care. And so by having an agency, we have the comfort in knowing that all of the other regulatory items are going to get taken care of properly, and we can really focus our medical care directly with the patient, with the surrogate, with the intended parent. So um, for us, we only work with agencies. I think for the intended parents, it is a huge plus. I mean, it's certainly costly, but I think what you're getting out of it, and again, I'm not an agency, so this is probably a better question for you, but from
Yeah,
my perspective, when I've had patients work with agencies, things just tend to be a lot more streamlined.
yeah. And it has to move a little bit more smoother. That way you have that extra person to kind of help, with appointments and scheduling and communication, and it just definitely flows a little bit better for sure.
Yeah, I also think that when you're coming into this as an intended parent using a surrogate, this is probably your first time doing it.
Yeah.
And it's nice to have someone who has done this 100 times or a
Yeah.
thousand times
Yeah.
because they're going to know sort of the pitfalls. And I think that's critical. I think the same is true for, and again, maybe you can speak to this, but I think the same is true for an IVF clinic. Um, I'm sure you've worked with IVF clinics that maybe this is their first surrogacy journey for them and clinics that have done hundreds of surrogacies.
Right.
Um, for us, again, I can remember back like 5 years ago, 6 years ago, working with some of our first surrogates. It's a little bit challenging until you have all of those protocols in place.
Right.
But now it's much more streamlined. And again, like I assume from the agency perspective, it's probably nicer to work with clinics that have had quite a lot of surrogacy experience.
Yeah. No, for sure. I absolutely agree with that. All right, let's see. What are the main factors that can affect the success rates of an IVF cycle?
Right. This kind of comes down to the three parties that are involved. And again, I'm gonna um, focus on surrogacy here because I think
Right.
that's probably where the audience is coming from. When we're talking about surrogacy, there are three parties, right? There is the individual that gives the male genetics, there's the female genetics, and then there's the uterus, the one that's carrying. And so each one of those will impact the success of the IVF cycle. And then I'll add the fourth one, which is basically the IVF clinic itself, because every
Mhm.
clinic is a little bit different. So, um, number one would be egg quality. The younger the egg, the higher the success rate is. If we compare um, eggs that get fertilized from someone who's 30 versus eggs that get fertilized from someone that's, let's say, 41 or 42, the success rate on the 30-year-old egg is going to be significantly better. There's no question about that.
Right.
Um, Sperm quality is going to affect this as well. Similarly, we are going to work with sperm of poor quality, and that is going to impact this fertilization rates poorly. If we have sperm that's really good quality, it'll improve it. So kind of those two things go hand in hand. Um, when we look at surrogates, we really want to make sure that we have a surrogate, ideally, that has had a successful pregnancy in the past. It's very hard. I'm not going to say it's impossible to work with a surrogate that has never delivered, but it's really not ideal. You want a surrogate that that has delivered, that has had uncomplicated deliveries, that is
Mhm.
generally healthy and is not going to run into medical complications for the next 9 months.
Right.
And I think if you can find a surrogate that kind of meets those qualities, then you'll probably can check off that kind of tick box as success.
Right.
Patients run into problems when they find a surrogate that has complicating factors, right? Maybe fibroids in her uterus. Maybe
Mhm.
she's had 3 C-sections before, which might not sound like a lot, but for a surrogacy, it
Right.
is. The more C-sections someone has had, sometimes they have complications in pregnancy with where the placenta attaches or having small babies grow, right? There are some I think characteristics that we look for like that. And then, of course, I think the fourth variable, which I mentioned, is the lab. And the lab is really important. When you choose your doctor and your lab, I mean, I would ask them, how are your success rates? What does your fertilization rate look like? What does your embryo development rate look like? And you want to make sure that you find a top tier lab. And I mean, again, having my own lab, there are so many tiny variables that we constantly look at to make sure that our outcomes are the best, right? The best that they can be.
Perfect. Okay. Thank you for that one. If the first embryo transfer doesn't result in a pregnancy, what steps are typically taken for subsequent attempts? Like, are we adjusting protocols or are we trying the same thing again?
Yeah. I think that it really depends on the situation. So we often think that the likelihood of success of transferring a single embryo should be roughly in the 70% range. So that still means that if everything goes perfect, and if you have a perfect embryo and a perfect uterus and a perfect protocol, 30% of the time you still fail, right?
Right.
Not because something needs to be changed, but that's just human biology,
Yeah.
essentially, at the end of it.
Right.
It's not, just like when a heterosexual couple is having sex while they're ovulating, there's not a guarantee that you get pregnant that month.
Right.
The same is true with embryo transfers. So we kind of have to first take a step back and look at this and say, okay, if this is the first failed transfer and everything else looked perfect, you may not have to adjust anything, right? Um, and you also have to figure that sometimes if you make an adjustment, you could make an adjustment for the worst, like, could make it worse. And we don't want to do that.
Right.
Um, Generally, what we do is we have a review where the case is brought up with myself, with my lab director, with the embryologist, with the clinical team, and we have this monthly. If there are any failures, and we kind of all pitch in our ideas as to what we think could be better or what we think went good and what we think went bad. And so that's the approach that we take at Perch. I think sometimes there are cases where we adjust protocols, and there's a couple different protocols that you could give a surrogate to prepare her for
Mhm.
a transfer. And there are some times where you look at everything and you say, look, everything looks really good. It was just not meant to be, and that's okay. And we'll try again. And more often than not, that second time works.
Yeah.
Generally, the way the numbers play out, and this has been sort of published multiple times now, is that if someone has 3 normal embryos, then there is a greater than 90% chance of a live birth. So, you know, the numbers today are much more in favor of live birth than they were, let's say, 25 years ago.
Well, that's definitely a step in the right direction for sure. And I can
For
only
sure.
imagine as
Yeah.
time goes on, the rates will probably be even better as we're learning more and, you know, more trial and error, all those things will help the odds.
They will be better. Yeah, they will be
Yeah.
better. The technology is improving every day.
Yeah.
The equipment is improving. So yeah, I mean, in my career again, which has been about a decade now, I've seen already improvements in national numbers um, from when I was in training till now, right? And I'm just talking national numbers, but
Right.
even internal numbers are better every year.
Yeah. And that's amazing. That's something that's really to be proud of for sure.
Yeah.
All right. Question number 6. What kinds of medical and genetic screenings are important for both donors and intended parents before proceeding with IVF?
Sure. Um, let's tackle genetic first.
Okay.
What we want to make sure essentially is that the genetic material from the sperm and the egg are a good match. That's kind of what we're asking about here. And what do we mean by that? We mean that both the egg source and the sperm source don't carry the same disease in their family tree. And I'll give you an example. One of the things we might look for is cystic fibrosis or Tay-Sachs or sickle cell disease, right? These are kind of common things that you may not be affected with yourself, but you might carry. Just like you might have brown eyes, but you carry the blue eye gene. So you could have a child with blue eyes. So same kind of concept here. So again, people might carry cystic fibrosis. That doesn't mean that they have it. It means that they are carrying it somewhere in their genetic makeup. But if both sperm and egg are carriers of the same condition, then there's a pretty high risk that the resulting embryo and baby actually are affected by it. Kind of like two brown-eyed people having a blue-eyed baby, right? You both have to have had carried the blue eye gene somewhere, right? Otherwise, the baby
Mhm.
cannot have blue eyes.
Yeah.
And so what we do for that is there are tests called expanded carrier screenings, and it's very standard to have both sets to check that. So you would check the donor, and then you would also check either the donor egg and the sperm or the egg source and the sperm source. Medical screenings, it really depends what's happening here, right? It kind of depends what kind of treatments are being done. So most of the time, the most basic medical screening we're checking is infectious screening, and that's because that's heavily regulated by the government. They obviously are making sure that there isn't transmission of an infection like HIV or hepatitis from one person to another, particularly if we're taking sperm and eggs and putting them in a third person, right? So those are, I would say, like the main medical screens that we check. But
Mhm.
we check other things too. So if you're going to need an egg retrieval procedure to remove your own eggs, then there are other medical screenings that we would check just as if you were having any other surgery. We want to make sure that you don't have anemia and that your blood count is good. We want to make sure that you don't have a thyroid problem. Sometimes we check vitamin D. So there are, a variety of health screenings we check, particularly for the donors or for anyone that's going to undergo an egg retrieval. For the sperm source, there aren't too many medical screenings. The basic screening we do is going to be the infectious screening and the semen analysis. And as long as those two are good, there's not much else to do. Of course, if the semen analysis is problematic or has some issues with it, then we sort of dive deeper and, we might look at testosterone levels, we might look at other hormones in the men, we might look at conditions like maybe they have high blood pressure or diabetes. So we'll dig deeper, but those are, I would say, like the main basic screenings that we're doing.
Okay. Wonderful. Okay. How have advances in genetic testing improved embryo selection and overall IVF outcomes? I guess that kind of goes along with the first, like, the couple questions ago that we were talking about advances. So,
Yeah. So genetic testing for embryos on a whole is called PGT, pre-implantation genetic testing. Um, it's then broken down into subsets of genetic testing because, as you can imagine, the word genetic testing is very abstract. I mean, what does genetic testing mean, right? Are we testing a chromosome? Are we testing a single change in the DNA? So it's kind of an abstract term. So when we look at genetic testing of embryos, we have to be a little bit more specific and say, okay, well, what are we actually talking about? Because there are different types of genetic tests that can be done on embryos. I would say that 99% of them is called PGTA for aneuploidy, and that's the one that I referenced in the past. That is when we take a small amount of DNA and we are able to determine if the embryo has all of its DNA or is missing DNA. That test would also identify things like gender, for example, because it can look at the X and the Y or the X and the X, so we know if it's a boy or a girl. That type of testing can also identify for problems like Down syndrome, because there you have an extra copy of a whole chromosome, so we would be able to identify that. There's some other syndromes like Turner syndrome or Klinefelter syndrome, Edward and Pitot syndrome, so different chromosomal symptoms that we can identify. There are things that we cannot identify. So, for example, if you're interested to see if the baby has a risk of autism, that is not something that we can identify on an embryogenetic test, even though we would love to. So the majority of the testing is called PGTA. It's changed a little bit over the last 15 to 20 years. And when I say changed, I mean that the methodology has changed in terms of how the test is run. And then really the depth of screening, meaning the amount of information that you get, has changed. So 15 years ago, 20 years ago, we were really only able to check the DNA status of a couple chromosomes, and today we're checking the DNA status of the entire genome. So that's kind of changed. Um, and the methodology has changed a little bit too, and probably the two most popular methodologies are called SNP arrays and then next-gen sequencing, if anyone wants to Google that. We won't go deep into it.
Okay.
But to know that both basically tell you, is all the DNA there and is it intact? Now, the advantage is that if someone has a group of embryos, let's say they have 4 embryos, and we know that, let's say we have some magic ball that we know that 2 of them are normal and 2 of them are abnormal. Um, in that situation, the maximum number of normal children would be 2. And whether you do the testing or not, you're only going to get 2 children from this group of 4 embryos. Again, assuming we know that 2 are normal and 2 are abnormal. So doing the genetic testing is not going to get you more babies or less babies. Like whatever is there is there. But what it does is it gets you to that point quicker. Because if we have to randomly select an embryo, there's a chance that we select a bad embryo, an embryo that is missing some DNA and therefore could fail or could lead to a miscarriage. And so the benefit of DNA testing is that we get to the more competent embryo quicker. And we don't have to go through multiple embryo transfer cycles with abnormal embryos. The other benefit is that we are reducing the rate of miscarriage, because we know that in a normal tested embryo, the rate of miscarriage is very, very low. But if the embryo is abnormal, the rate of miscarriage is very high. It could implant, it could survive for a week or 2 or 3 or 4 weeks or 8 weeks, and then eventually they will miscarry. So those are the 2 biggest outcomes: is one, faster time to pregnancy and less embryo transfers, which is critical, particularly when you're using a surrogate, because it's expensive to put the surrogate through a transfer. And then lower miscarriage rate, which again, particularly if you're using a surrogate, you would like to get it right and get it right on the first try.
Okay.
Um, I'm just gonna like spend 30 seconds on some other genetic tests that people might have questions on, but
Okay.
that was 99%. 1% of the genetic testing that we do on embryos is for those specific mutations for couples that know that they carry cystic fibrosis or they know they carry sickle cell. We can detect those as well. That's a separate test. It's usually done in unison with the first one, but really only amounts to a very small proportion. But we are able to do that scientifically.
Wow, that's pretty fascinating. I know we had an intended family that I was doing a meeting with the other day, and they were concerned about a disorder that would leave the child deaf. And unfortunately, that was one that could not be picked up on the PGT testing. So they would need further testing in the future. But it's nice to know that there is certain ones that can be detected if you're looking for it right now.
Yeah, and that number has gone up and up. So, it used to be 100 diseases that we could detect. Now it's like over 600.
Wow.
And there are some deaf genes that we know about, and some, unfortunately, that we don't know about. So, every person's situation is a little bit different.
Yeah, awesome. Okay. We did have a question, but we'll wait until the end to kind of touch base on those. So we will move on
Sure.
to the next one. What are realistic success rates for IVF within the surrogacy process, and how can intended parents stay hopeful while understanding the potential challenges involved?
Um, you know, Again, like success rates are highly tied to the age of the egg and the quality of the sperm. So it's hard to give a specific rate, but let's just look at some kind of basic metrics that I think might put things to perspective. So assuming that you did your IVF cycle and you did the embryo testing and you have an embryo that is genetically normal and good, has a good grade, like an A or B grade, what we know is that the chance of success of a positive pregnancy, again, every clinic is a little bit different, but broadly is about 65 to 70% with one embryo. If you have two embryos, your success is higher because you have another opportunity if the first one fails. And so it's probably 75 to 85%. And if you have three normal embryos, then it should be closer to that 90% range. And that's why generally when I work with intended parents and we're working on banking embryos and freezing embryos, we like to get to a point where we have at least two or three normal tested embryos frozen before we move on with the surrogate process. This way we kind of can almost ensure, it's never 100%, but give them as best of a chance as possible to actually have a successful pregnancy.
That makes sense. All right, I think we have a few more. Let's see. Okay, how can family medical history influence IVF planning and decisions around genetic testing or donor selection?
Right. Yeah. So this, I think, kind of goes back to the original question in terms of screening. I think if let's use BRCA or BRCA as an
Mhm.
example here. So there is a gene that causes cancer in men and women, actually. And so if you already know that your family has that gene and you know that it's been passed down, there's basically two options. One option is if you're the female, you can use an egg donor, and hopefully that egg donor doesn't have the gene. She shouldn't. Again, if the gene is on the male side, you could use a sperm donor. So that would be one option where we look at kind of your family history and say, okay, maybe it's worth it to use genetic material from someone else so that this gene that causes cancer, which is really severe, is not going to be a factor. The second option is to do that very special genetic test called PGT, and this one is called M. M stands for monogenic disease. So a disease that's caused by a single DNA change. And so in those cases, we can still use both parties' eggs and sperm, but what we're doing is we're specifically looking for that abnormality in each embryo. And we might find that, embryo number one, two, and three are all affected with it, but embryo number four did not inherit this BRCA gene or whatever gene we're talking about. And so that is the embryo that we focus on transferring. And so this is how we sort of like make that decision around what to do when there is some significant family medical history that influences the picture here.
Okay. Alrighty. How does the IVF and surrogacy process differ for various family types, such as single parents, same-sex couples, or traditional couples? And what unique considerations do intended parents in each group typically face?
Well, um, every journey is special, right? Every journey is unique. So I, you know, every couple that comes to me, or whether they're a couple or they're single, like they all have their own unique story. Um, and there's probably, 1,001 different permutations of what needs to be done for each journey. So it's um, maybe not so easy to kind of look at every single one, but looking at a couple of these individual items, I would say if you cannot carry, or if you don't have a uterus, then you need to use a surrogate, right? There's really
Mhm.
no other way to do it. If you are a same-sex couple and you're two men, then you need an egg, so you'll need an egg donor. If you're a same-sex couple and you're two women, then you need a sperm donor, and you still need an egg, so one of you would have to provide the egg.
Mhm.
And if neither of you could provide the egg, then you would use an egg donor and a sperm donor, right? So, every situation is a little bit different. For traditional couples that are heterosexual and that can use their own genetic material, their own eggs, their own sperm, then it really just depends on whether they are able to carry the pregnancy or not. And so if they're able to carry, then we would do standard IVF or traditional IVF, and the woman would carry. And if there is some issue, it could be a medical issue or a surgical issue or some reason that she can't carry, then that's the case where even in a traditional couple, we would introduce the idea of a surrogate to carry that pregnancy.
Okay. Yep, that makes total sense. What kinds of emotional and practical support does your fertility clinic offer to individuals and couples facing infertility?
Well, I mean, we have an entire team of people behind you, right? So we have nurses and coordinators and myself as the medical director and our embryologist. And so we're sort of an extension of your family. So, we're the ones that are here to help support you throughout the entire journey. My team is extremely knowledgeable. You have your agency to support you. And then we also have some recommendations for people that need additional support, whether it's behavioral health support or nutritional support, right? There's a number of different things that we can recommend people to go to. And if that's the case, that is something that we offer. Other than that, sort of like the logistical support for us is streamlined. So I think and probably when you work with most fertility clinics, but I can't speak about everyone, but certainly when you come to work with us, the approach should be fairly streamlined. So we don't want you to have to think about, do I need to do this test? Do I need to do that test? When do I have to do it by? We try to approach it where we have sort of like a checklist, almost like a journey. And we pretty much walk you through that journey from step 1 to 2 to 3 to 4 until you finished. And so in the beginning, you have a consult with me and we talk about sort of the whole process. Then our team puts together basically this journey or package for you so that okay, these are the next 5 steps. And then we just kind of take each step at a time.
Awesome. It does sound like everybody really has so much support, which is fantastic.
Yeah, for sure.
All right. I think we only have two more. Let's see. What recent advancements in egg and sperm freezing, storage, and handling have improved accessibility and success rates for intended parents pursuing surrogacy?
Okay. Um, I mean, one thing that has changed from when IVF first started is the method at which we freeze eggs and embryos. And so we used to use one method called slow freezing, which worked well, but the survival rate was not so great. And now, pretty much all the clinics, I can't imagine there are any clinics that are still doing that, but pretty much all the clinics have moved to what's called vitrification. And it's sort of this like very quick flash freeze method. Um, the idea behind it is that we are able to remove the water from the eggs and the embryos. And when we freeze them, since there's no water inside, there's no crystals that form. Kind of like when you freeze ice, you get an ice crystal. So we want to prevent that. And so the survival rates and the thaw rates are just way, way better, right? It's exponentially better. I think the other thing that has changed is that we are seeing a lot more third-party vendors now that are offering long-term storage. There is a company that we work very closely with called Tomorrow, TMWR, TMRW, and they offer a long-term robotic storage system. So it's very controlled environments, and we don't have to worry about, the power going out or something like that. We're very confident that these eggs and embryos and sperm are going to be stored in a way that is not going to impact the survivability and their competency when they thaw.
Wow, this is actually really fascinating. That's
Yeah.
really cool to know
I'll
about
add one
that.
more thing. And again, this is something that we do. Maybe we're a little bit unique, but we are super critical about how we handle samples. And so typically you would have something like the name on a sample, like first name, last name, and the date of birth. Um, we obviously do that. Typically, you would have two people double check to make sure that you're thawing the right sample, right? And we do that. We, again, at Perch, we take it a step further and we actually use these small, I don't want to call them chips, but they're RFID tags. So every sample actually has not only a physical label on it, but also an electronic tag so that we can never pull a sample out without the computer also verifying, not just two humans verifying, but the computer is now verifying, yes, this is the correct sample for the correct patient. And so I think in terms of long-term storage, all of our tissues are stored with these RFID tags at Perch. And
Mhm.
that's like a third sort of triple check to make sure that everything is as it's supposed to be.
I love that. Like the accountability factor is there, so you really
Right.
have nothing to like fear that
Right.
something would go wrong and the wrong one is used or something like that. That's
Right.
fantastic. Yeah.
And we give our patients access to some of this electronically. So they know, hey, I can see my eggs or my embryos are
Hmm.
stored in this tank. And we can
Yeah.
see it because the RFID reader, the scanner, is actually always scanning it. It knows which eggs are in there and which eggs are not in there, which embryos are in there, which embryos are not in there. So the patients sort of have that in their hands, which is really nice.
That's really cool. That's really cool. How do doctors determine the optimal timing for embryo transfer, and why is timing so critical for successful pregnancy and surrogacy?
Yeah. So when we're transferring an embryo, what we are trying to do is basically mimic the natural human endometrial and hormonal cycle, right? We want to basically bring the surrogate to a point where her uterus is receptive and open to an embryo. And if you transfer an embryo, if you take that embryo and you put it in someone's uterus at any day of the month, it's probably going to fail. And that's
Hmm.
because that embryo needs to bind from a chemical perspective, from on a microscopic receptor level, it needs to bind with the endometrium or with the tissue in the uterus.
Hmm.
And it can only bind once all of the stars are aligned hormonally. And so that's
Hmm.
our job. Our job is basically to give the surrogate a set of medications, things like estrogen and progesterone, to get her body to a point where her uterus has now opened the door, figuratively speaking,
Hmm.
and says, okay, I am ready for that embryo now. And what's critical about timing here is that that window, which we call window of endometrial receptivity, so that window is really only open for something like 12 to 24 hours. So it's like very narrow. Think
Yeah.
about it, you have a full
Yeah.
month, but there's only 12 hours or 24 hours where that window is open. And so it's very critical that when your physician or your clinic is working with your surrogate, that they are really watching the surrogate carefully, really watching the levels, making sure that the timing is correct down to the hour.
Wow.
Because if you're outside of the window, it doesn't necessarily mean failure, but certainly it's like a bell curve, right? So in the window, you would have the highest chance of success, but 12 hours left or 12 hours right, 24 hours left, 24 hours right, the success rate is going to drop precipitously, and we want to avoid that.
Yeah. Okay. That makes a lot of sense. That's why we have all the monitoring appointments for the surrogates. And I remember going to all of those and making sure that all your
Right.
numbers are perfect before they will even think
Yes.
about letting you transfer. And they will cancel
Right.
it if it's not, which is
Yep.
great too.
It is good. I always tell people that like I hate being the bad guy sometimes, but you will thank me for it. And I have had
Yeah.
to cancel transfers. Like
Yeah.
I have, you look at something and you just don't get a good feeling. The levels are just not right. And
Yeah.
embryos are really, they're precious. They're very hard to get. It takes a long time
Yeah.
to get an embryo. So once you have one like this beautiful embryo, I feel like it's our responsibility as physicians to make sure that we are going to put it in the most optimal environment.
Hmm.
And that is going to get you the best success. And if you're at a place that will just put it in no matter what because they just want to get the procedure done, right? To me, that's going to be a disadvantage to the intended parent. Um, and it's a hard conversation when you have to cancel someone because now they've invested already, weeks of time and money. But I always tell people like, just think about this for a minute. You are going to have this baby for eternity, right? For your life. When this child turns 17 years old, you're not going to think about how, oh, the child could have been 1 month, younger. No one
Yeah,
thinks
yeah,
about that,
yeah.
right?
No,
Like
absolutely.
we
Yeah,
just don't think about that. Like a month is nothing compared to the lifetime that you're going to have this baby. And if canceling the cycle and redoing it means a success, then you should do that.
yeah. And I know me as a surrogate, I feel the same exact way. Like I would much rather cancel an entire cycle knowing that the next cycle it has a better chance of succeeding. Even though, the preparation is hard. It's not easy to go through. And I think a lot of people don't understand that aspect of it. It's very hard on the body to do that. However, like you said, what's another month? Like if this is better success, waiting that month or 2 months and making sure everything aligns better, I would much rather wait and make sure that it is because it is precious. The embryo is so precious. So
Yeah, you should listen to Samantha's advice.
yes, listen to me. I know little bits of what I'm talking about. All right. I do think that was the last question.
Great.
Let's see real quick. Yep. Okay. So that was the last question. I know that somebody did ask a question in the comments, so I'm going to pull that up really fast. And if anybody else has any other questions, I do believe we have a couple more minutes. So the first one I believe was talking about the PGT testing. Is that testing how you grade the embryo?
Right. So it's not exactly how we grade the embryo. So just to kind of reiterate, there's two ways that we are going to assess the quality of the embryo. The first way is what we call morphology grading, and that's grading is the more common term, but we call it morphology, and that's where we're physically looking under the microscope and we're looking at the embryo and we're looking at the cellular structure and we're giving it a grade A, B, C, D, best, good, not so great, worst. The second way we would grade the embryo is the actual genetic testing. And I hate to use grade, it's really just the second way we evaluate whether the embryo is competent. And that's the genetic testing called PGT.
Perfect. All right. Another question I see in the comments is egg retrieval risky? Could it make it harder to get pregnant naturally in the future by doing an egg retrieval? Okay, I
Sure.
understand that now. Okay.
Yeah, sure. I mean, it's a great question. I tell people that any medical procedure carries risk, period. In fact, anything you do in life carries risk. If you cross the street, there's a risk a car will hit you. So, for sure, everything in life carries risk. Generally, what's good about egg retrieval, and not just the retrieval, but also the entire IVF cycle and the stimulation, um, generally is a very, very low risk, minimally invasive procedure. Um, the the risk of the stimulation, really like the biggest risk is to overstimulate someone, and that's called hyperstimulation. I think today with the medications that we have, we rarely see it. I mean, like knock on wood, in 10 years, I've never had to admit someone to the hospital for hyperstimulation. It is something that happened in the past, but we don't really see it too common anymore. And then the risk of the actual egg retrieval is minimal. It's done with a very, very fine needle, similar to drawing your blood. And in terms of making it harder to get pregnant naturally, I mean, I'm not aware of any data at all that supports that. So I've had people that do 3 IVF cycles to get embryos, not because they're infertile, but because they maybe weren't ready for a child just yet, but they're getting older. And then, they'll call me a year later and they say, hey, by the way, we got pregnant on our own and we're going to use our embryos for baby number 2 or 3. And so no, there shouldn't really be any risk to getting pregnant naturally if you do an IVF cycle.
Okay. And I'm going to ask one because I know that when I am doing my job, I bring in the surrogates to help them, start their journeys. And one of the questions that I often get asked is, what are the risks of surrogates not being able to get pregnant naturally in the future?
It's the same answer. So
Okay.
the bigger answer is there is no risk.
Okay.
It's just like if you were to get pregnant naturally, there really isn't a risk. I suppose one thing you have to think about, and again, It doesn't matter whether you get pregnant naturally or whether you get pregnant with IVF, you could have a complication in pregnancy. And again,
Sure.
that's true no matter what.
Right.
So that is something to think about when you're doing a surrogacy. We can't say that it is risk-free. It's the same risk that anyone else were to have if they're pregnant.
Got it. Okay. It's usually what I say.
Good.
I feel like I should be like an endocrinologist. I feel like I
Yeah,
like do your job.
I, you know what? We could use the help. So happy to have you in the office
I
anytime.
will go back to med school. It's fine. Um,
Only
just
15 years,
right. I have all the time in the world.
right?
All right, so it looks like those were the only questions that we had. So I guess at this point we can conclude our session, but thank you so much for sitting with me and answering some of those questions. I know they were very informative. And if at any point in time anybody is interested in reaching out to ACRC to start your surrogacy journey, feel free to take a screenshot of this screen to keep all of the information on how to contact us. And we would absolutely love to help you guys all start your journey. And hopefully, we will be able to have a good working relationship with you, Dr. Olcha, in the future.
For sure. Yeah, this was great. And thank you so much for having me. If anyone's interested in getting more information about our services, they can go to our website, which is perchfertility.com, P as in Peter, PERCH fertility.com. And happy to help you out.
Yeah. And again, wonderful, beautiful facility. You will be
Thank you.
very, very impressed when you go there. So, all righty. Thank you so much. And I hope you
Take
have
care.
a great day.
Bye bye.
Bye.